So, coming towards pseudoaneurysm cases, left is the sagittal graphic and it shows the sequelae of closed head injury. A pseudoaneurysm of distal anterior cerebral artery is noted. A lesion is also, this lesion is contained by the cavitated clot that communicates with the anterior cerebral artery. Right is the axial non-enhanced CT scan in a 52-year-old woman with sudden onset of severe headache 2 weeks following the closed head injury, and it shows the subarachnoid hemorrhage and focal hematomas within the corpus callosum. A subtle focus of relative hypodensity is present within the genoclot. Left is the emergent CT angiography in the same patient, and it was obtained and it disclosed an irregular contrast-filled lobulated outpouching of the anterior cerebral artery. Right is the sagittal CT angiography reformatted from the axial source data in the same patient, and it nicely depicts the source of the callosal hematoma. A bleeding traumatic pseudoaneurysm was found at surgery. On the left, that's the autopsied brain image, which was seen from below, and it shows the ectatic and very tortuous basilar artery with extensive yellow plaques of atherosclerosis. No focal areas of dilatation are seen, and so this is vertebrobasilar dolichoectasia, a relatively common finding in elderly patients. Right is a sagittal T1 weighted MRI in a 76-year-old man with headaches, and it shows a very elongated, unusually ectatic basilar artery. And the basilar artery, the basilar tip elevates and indents the third ventricle. Left is the axial T1 contrast enhanced FSMR, and it shows the strongly enhancing basilar bifurcation as it indents the inferior third ventricle. Right is the coronal T1 contrast enhanced MRI, and it shows the extremely ectatic elongated basilar artery, which is characteristic of typical vertebrobasilar dolichoectasia. Left is again a autopsy image, and it shows a very tortuous vertebrobasilar artery with an atherosclerotic fusiform aneurysm that extends from the vertebral artery junction to the distal basilar bifurcation. Right is the oblique DSA image in the same patient 2 years later, and it shows the dolichoectasia of the proximal distal vertebral arteries. A fusiform ASVD aneurysm lies between the arterial ectasias. The residual lumen is indicated with the arrow, and the aneurysm had enlarged but also partially thrombosed, leading to mild TIAs. Left is the non-enhanced CT scan, and shows typical hyperdense atherosclerotic fusiform aneurysm with mural calcifications. Also noted is the extensive calcification of the internal carotid, right middle cerebral arteries. Right is the series of MR images shows the bizarre appearance of classic atherosclerotic fusiform vertebrobasilar aneurysm. On the left is the dissected circle of Willis in a hemophiliac child with HIV, and it shows the non-atherosclerotic fusiform vasculopathy, which is involving multiple vessels and most striking in the MCAs. Right is the coronal MIP view of a CT angiography in a 25-year-old HIV-positive man with a history of multiple strokes, and it shows the calcific vasculopathy with a fusiform aneurysm of the left distal ICA, proximal ACA, and MCA. Left is the axial T2 weighted MRI. That's the axial T2 weighted MRI in the same patient, and it shows the flow void of the left MCA fusiform aneurysm. The right MCA is also enlarged but completely thrombosed. Note the encephalomalacia from a remote right MCA territorial infarct. On the right, that's the anteroposterior view with the SSD of the left carotid DSA in the same patient, and it shows the fusiform aneurysmal vasculopathy. Left is a sagittal graphic, and it shows a blood blister-like aneurysm, which is seen to be arising from the dorsal superolateral wall of a supraclinoid internal carotid artery. The blood blister-like aneurysm is covered only by a thin fibrous wall. Right is the reformatted lateral view of the CT angiography in a patient with subarachnoid hemorrhage on non-enhanced CT scan, and it shows a small, broad-based, contrast-filled hemispheric bulge along the greater curvature of the internal carotid artery. The left image is a lateral DSA in the same patient, and shows the classic appearance of a blood blister-like aneurysm, and it confirms the CT angiography finding of a focal broad-based hemispheric bulge. Right is the lateral right ICA DSA, and it shows a small hemispheric bulge along the ventral paraclinoid ICA in a patient with subarachnoid hemorrhage. Adjacent irregularity of the ICA lumen more distally likely reflects the associated dissection or ASVD. There is vasospasm involving the anterior cerebral artery and a posterior communing artery in fundibulum. So coming towards the stroke radiology, left is a graphic and it shows the cortical MCA distribution in the red, that is middle cerebral artery distribution in the red. The middle cerebral artery distribution typically involves the majority of the lateral surface of the hemisphere, including the frontal, temporal, and parietal lobes. In addition, the majority of the lenticular striate arteries arise from the M1 segment and they supply the basal ganglia. Right is the axial CT image and it shows a large left MCA distribution infarct with involvement of the basal ganglia, indicating the involvement of the lenticular striate perforating arteries, which typically arise from the M1 segment. Now, this left graphic shows the ACA, that is the anterior cerebral artery, cortical vascular territories in green. The anterior cerebral artery supplies the medial anteroinferior frontal lobe, the anterior two-thirds of the medial hemisphere surface, and a variable amount of territory over the cerebral convexity. The corpus callosum is also typically supplied primarily by the ACA branches, callosal, perforating, pericallosal, and posterior splenial branches. Right is the axial DWI MRI and it shows the diffusion restriction in the left anterior cerebral artery distribution within the medial paraphalcine frontal lobe. Left graphic shows the typical posterior cerebral artery PCA vascular territory, including the occipital lobes, the inferior temporal lobes, and the medial posterior one-third of the interhemispheric brain. Patients with PCA ischemia most commonly present with visual complaints. Large vessel atherosclerotic strokes represent 40% of the strokes. The carotid bifurcation is the most common site of atherosclerotic plaque. Axial DWI MRI shows diffusion restriction in the occipital lobe related to the PCA ischemia. DWI, that is diffusion weighted imaging, is the most sensitive MRI sequence for acute ischemia. Left is the axial graphic and it shows the major penetrating artery distributions, the pontine and thalamic perforating arteries, as well as the medullary perforators which arise from the vertebropasilar system. The medial and lateral lenticular striate arteries arise from the anterior circulation and they supply the basal ganglia. The choroidal arteries are shown in magenta color. Right is the axial DWI MRI sequence and it shows the diffusion restriction related to the acute ischemia in a pontine perforating artery distribution. So left is the axial graphic and it shows the cerebellar artery distributions. The superior cerebellar artery is shown in green color and it supplies the superior cerebellum. The posterior inferior cerebellar artery, that is spica, is shown in peach color and it supplies the majority of the inferior cerebellum and lateral medulla. The anterior inferior cerebellar artery it's shown in yellow color and it supplies the petrosal surface of the cerebellum. Right is the axial T2 weighted MRI and it shows the hyperintensity in the right inferior cerebellum and lateral medulla related to a pica infarct from a vertebral artery embolus. Left is the axial T2 weighted MRI and it shows hyperintensity and local mass effect in the right superior cerebellum related to an acute superior cerebellar artery infarct. The superior cerebellar artery infarcts may involve the superior cerebellum and the upper lateral pons. Right is the axial DWI MRI image and it shows the acute diffusion restriction in the anterior inferior cerebellum laterally in an ICA distribution. ICA primarily supplies the ventral pons and petrosal surface of the cerebellar hemispheres, the brachium pontis, the flocculus, and the inner ear, as well as the cranial nerve 7 and cranial nerve 8. So left image is a whole brain graphic and it shows the major arterial supply to the hemispheres. The middle cerebral artery is shown in red and it supplies the lateral aspects of the frontal and temporal lobes. The anterior cerebral artery is shown in green and it supplies the medial hemispheres. The posterior cerebral artery is shown in purple and it supplies the occipital lobes and inferior temporal lobes. The watershed zone is the border between the major vascular territories. Axial DWI MRI shows restriction in the left MCA territory with preservation of the basal ganglia. The MCA territory is the most common location for ischemic stroke. Left is the axial CT perfusion cerebral blood flow, that is CBF color map, and it shows a large area of decreased blood flow in the left hemisphere related to the hyperacute MCA ischemia. Right is the axial CT perfusion cerebral blood volume color map in the same patient, and it shows a much smaller area of decreased blood volume. The CBV is a marker for the ischemic core, and this CBF FCBV mismatch correlates with the presence of a large ischemic penumbra, which suggests that the patient would benefit from the intra-arterial thrombolytic therapy or clot retrieval. Left is the lateral gross pathology, and it shows a chronic middle cerebral artery infarct with hemorrhage and encephalomalacia in the frontal operculum and temporal lobe. Right is the axial flare MRI, and it shows multiple hyperintense foci in the watershed zones between the major cerebral artery territories, that is MCA, PCA, and ACA, related to acute ischemia from hypoperfusion. The posterior confluence, where all the three vascular distributions meet together at the vertex, is especially vulnerable to cerebral hypoperfusion. So left is the coronal oblique graphic of the rostral basilar artery, and it shows the typical arterial supply to the medial thalami by multiple posterior cerebral arteries and basilar tip perforators, multiple PCA and basilar tip perforators. A right panel shows the anatomic variant, that is the artery of Percheron, in which a single large perforating artery from the P1 supplies the bilateral thalami and the medial midbrain. Right image is the axial flare MRI, and it shows the hyperintensity in the bilateral medial thalami related to an acute artery of Percheron infarct. Extension to the medial midbrain is often present. The left image is again the axial DWI MRI, and it shows hyperintensity related to the acute ischemia in the posterior limb of the internal capsule in an anterior choroidal artery distribution. The anterior choroidal artery typically supplies the lateral midbrain, uncus, thalamus, posterior limb of internal capsule, and the optic tract. The posterior choroidal artery typically supplies the pulvinar, thalamus, medial temporal lobe, splenium, and choroid plexus. Axial CT shows a classic thalamic hypertensive hemorrhage, the second most common cause of stroke. Left is the axial CT, and it shows bilateral thalamic hemorrhage related to deep venous thrombosis. Venous thrombosis risk factors include pregnancy, trauma, dehydration, infection, oral contraceptives, coagulopathies, malignancies, collagen vascular diseases, and protein C and S deficiencies. Right is the axial SWI MRI image in an elderly patient, and it shows the extensive susceptibility artifact related microhemorrhages in the bilateral hemispheres. Pattern is typical of cerebral amyloid angiopathy. So left is the axial graphic, and it shows the evolution of parenchymal hemorrhage from hyperacute intracellular oxyhemoglobin to acute intracellular deoxyhemoglobin with surrounding edema. Early and late subacute intra and extracellular methemohemoglobin respectively are followed by a chronic cystic cavity with a hemosiderine stain. Right is the axial non-enhanced CT scan, and it shows a hyperdense mass related to an acute left cerebellar hemorrhage with minimal surrounding edema in a patient with hypertension. Left image is the axial T1 weighted MRI in the same patient, and it shows the cerebellar hemorrhage is predominantly iso-intense and mildly hyperintense to the surrounding brain parenchyma, indicating hyperacute blood products. Axial T2 weighted MRI, right image is the axial T2 weighted MRI in the same patient, and it shows the hyperacute hemorrhage to be hyperintense to the surrounding brain parenchyma with a peripheral hyperintense rim. Intraparenchymal hemorrhage evolves from peripheral to central, with the central core maturing more slowly. So left image is the axial T2 weighted MRI, and it shows a large hypertensive hemorrhage in the left basal ganglia. It shows early subacute blood products that are predominantly hypointense with surrounding edema. The anterior aspect of the hemorrhage shows hyperintense signal suggesting more acute blood products. Right is the axial SWI, and it shows the hypointense hemorrhage and multiple other foci of susceptibility from hemosiderin related to remote microhemorrhages from chronic hypertension. Left is the axial T1 weighted MRI, and it shows hemorrhages in an amyloid angiopathy patient. There is a hyperacute isointense and an acute early subacute that is hyperintense left posterior hemorrhage, as well as a late subacute that is hyperintense right temporal hemorrhage. Right image is the axial T2 weighted MRI, and it shows the heterogeneous bright signal in the hyperacute portion and the low signal in the acute slash early subacute portion of the posterior hemorrhage. The late subacute hemorrhage has bright T1 and T2 signal intensity. Left image is the axial DWI MRI and 21 hours after the initial imaging, and it shows that the signal on DWI is mostly determined by the underlying T2 effects with T2 shine through. In the right subacute hemorrhage and T2 blackout in the acute or early subacute hemorrhage. Axial right image is the axial ADC image, and it shows that the signal on DWI is mostly determined by the underlying T2 effects. Only the acute or early subacute hemorrhage shows low signal on ADC, while increased diffusivity is seen in the late subacute right temporal hemorrhage. Left image is the axial CT scan, and it shows a hyperdense hematoma centered in the left external capsule and putamen with associated edema and mass effect, as well as intraventricular extension of the hemorrhage. This is the most common location for a hypertensive hemorrhage. Right is the axial GRE MRI in a 71-year-old male, and it shows an acute hypertensive hemorrhage in the left cerebellar hemisphere with extension to the fourth ventricle. The posterior fossa accounts for 10% of all hypertensive hemorrhages. Left is the axial CT scan in a 58-year-old hypertensive female, and it shows a hyperdense hemorrhage in the right thalamus with surrounding edema. No additional imaging is required in this patient. Right is the axial CT scan in this 5-year-old, and it shows a large frontal lobe hemorrhage with surrounding edema and mass effect. Additional imaging revealed an underlying cavernous malformation. In children, vascular lesions represent 50% of all intracranial hemorrhages. So left image is the axial CT scan and in a 73-year-old male, and it shows an acute frontal and parietal lobe hemorrhage. MRI showed underlying enhancement, and biopsy disclosed a metastatic disease related to melanoma. Right is the axial gross pathology section through the middle of the cerebellum, and it shows an acute spontaneous intraparenchymal hemorrhage. Also noted is the atherosclerosis in the basilar artery. No underlying lesion was identified in this patient with chronic hypertension. Left image is the axial non-enhanced CT scan, and it shows what appears to be a classic hypertensive striatocapsular hemorrhage with intraventricular extension. However, in this young patient, underlying etiologies must be considered, including the drug abuse and vascular lesions. Right image is the anteroposterior DSA image from a right internal carotid artery injection, and it shows an avascular mass in the basal ganglia hematoma with midline shift of the anterior cerebral artery. There is a cluster of abnormal arteries that is AVM, which is fed by a large anterior choroidal artery. Left image is the axial GRE image, and it shows a large occipital lobe hemorrhage and multiple other foci of susceptibility artifact or blooming related to the hemosiderin deposition in this elderly patient with cerebral amyloid disease. The MRI was done to exclude an underlying mass. The right image is the axial T1 contrast enhanced MRI, and it shows the lobular cerebral hematoma in the left temporal lobe. Also noted is that the fluid levels are noted in the hematoma from brisk bleeding. The more avidly enhancing region in the sulcus represents the pseudoaneurysm. Left is the axial CT scan in a 61-year-old female with a history of hypertension, and it shows the classic appearance of a left basal ganglia hemorrhage involving the putamen and external capsule, that is striatocapsular region. Note that the additional areas of periventricular hypotensity likely related to chronic small vessel ischemia. Right image is the axial SWI image, and it shows a large hypertensive basal ganglia hemorrhage as well as multiple foci of susceptibility artifact from the hemosiderin deposition related to the microhemorrhages from chronic hypertension. Left image is the axial graphic, and it shows a classic acute hypertensive basal ganglia slash external capsule hemorrhage with dissection into the lateral ventricle. Hemorrhage extends through the foramen of Monro to the third ventricle. Right is a coronal CT angiography in a young patient with a right basal ganglia hemorrhage, and it shows displacement of the lenticular striate arteries medially compared to the normal left side by the hematoma. There is no spot sign that would indicate the active bleeding. No underlying vascular lesion is present.